about the fetal circulation and how most of the blood is bypassing the lungs in utero. And the reason for that is there's no gas exchange that occurs in the lungs. The blood flow that goes to the lungs is only for development of the lung tissue. All the gas exchange takes place in the placenta with the mom's blood. However, when you do an ultrasound of the fetus, you see the chest moving, just like it would with breathing. So that's just developing the muscles. So at birth, the muscles are ready to breathe. However, the bottom line, or that blank line, needs to be filled in. It says fetal lungs make breathing-like movements, but there's no gas exchange occurring.
Good question.
Yes.
Is there an answer for the negative parts of the fetus that is towards the least amount of?
Oh, okay. So the most oxygenated blood goes to the head. I told you that already. And then the least amount would be the legs and the lower part of the body. All right, so the transition that occurs at birth, when the umbilical cord is clamped, this causes a high vascular resistance. So when blood is flowing to the placenta, there's an extensive amount of blood vessels going to the placenta. And when you clamp off all of those blood vessels, now you've got a lot of blood, but it's not going to the placenta. So that causes high pressure inside the vessels in the fetus. So the left heart will experience high pressure, and that's going to cause the foraminal valve to close. Because in utero, there was higher pressure in the right atrium, and it was pushing the valve open. Now you've got higher pressure in the left atrium, and that pushes the valve closed. Another thing that happens with the first breath is the pulmonary vascular resistance decreases. So in utero, you've got the muscles around the pulmonary arteries are constricted, and they stay constricted. But once during transition and that first breath causes the pulmonary vessels to dilate, and now instead of that 10% just going to the lungs, now you've got the full 100% of the blood flow going to the lungs. And then the other change is the ductus arteriosus. It's no longer the pathway of least resistance. So within hours, days, I think 3 days of life, it's completely closed. And it's just because it's not being used, and it slowly closes itself off. Most deliveries are uncomplicated. With a vaginal delivery, the head will present first. And the head is the largest part of the fetal body. So with the head going first, it kind of makes way for the rest of the body to follow. However, if the fetus is upside down and the feet come out first, then the head can get stuck in the birth canal, and it can cause no blood flow going to the brain. So if the feet present first, that's called breech delivery. This happens in about 4% of all births. All right, I have some pictures of a delivery. Let's see. I'll show you a vaginal and a C-section.
Put them in the theater.
See if we get. Oh, it spends like a minute just going through normal anatomy. This is meant for EMS students. I kind of took their video.
Because the placenta is during pregnancy is expelled after the baby is delivered. The fetus is joined to the placenta by the umbilical cord, the unborn baby's lifeline. It's usually about 20 inches long and 1 inch in diameter, resembles a sturdy plastic rope. Inside the umbilical cord are 3 blood vessels that carry food and waste products to and from the fetus. Like the placenta to which it is attached, the umbilical cord is completely expelled during the birth process. While developing in the uterus, the fetus is completely enclosed in a thin membrane called the amniotic sac. This sac is also attached to the placenta. It is sometimes called the bag of water since it contains between 1 pint and 1 quart of liquid. The fluid insulates and protects the baby during pregnancy. During labor, the sac breaks and fluid gushes from the birth canal. Labor is the term used to describe the process of childbirth. When the mother-to-be is in labor, muscles of the uterus contract at ever-shortening intervals. It is this series of contractions that force the baby and later the placenta, or afterbirth, into the outside world. The fetus enters the birth canal through an opening in the uterus called the cervix. During the first and longest stage of labor, the cervix gradually stretches until it is large enough for the baby to pass through. The contractions of the uterus, which bring about the stretching and move the fetus into the birth canal, cause the pains known as labor pains. Most women giving birth for the first time will remain in this stage of labor for about 16 hours. When labor begins, contractions typically are about 30 minutes apart. The cervix is dilated 2 to 3 centimeters. As the birth approaches, contractions occur every 3 minutes, and the cervix dilates to 10 centimeters. The second stage of labor begins when the baby starts to move into the birth canal or vagina and ends when the baby is delivered. During this stage, contractions become even more frequent and labor pains more severe. The woman will feel the need to push down at this point. Birth is imminent. The second stage of labor may last a few minutes or up to 2 hours. During the third and final stage of labor, the placenta separates from the uterine wall. Contractions return, and the placenta and fetal membranes are expelled from the uterus. This usually takes place within minutes after the birth. However, in some cases, it may take up to half an hour or more.
There's a scalp monitor attached to the head to monitor the heart rate.
I'm about to ask you what that was. I've never seen it take this long.
You okay?
No, like the way she's pulling, not like watching it. I've seen births in real life. These words.
They made it.
Really? My friend still regrets it.
You made it.
The head is still attached after all that pulling. Okay. I don't know if they show the warm towels. No, it goes right to mom, I guess.
Oh, the placenta where?
And that's the placenta.
So it just comes out like. Oh my god.
That is, yeah, that's amazing.
All that blood.
Yeah.
That's amazing.
I'd like to go back to the babies.
And then she goes to show them how to do CPR.
Is it mad at the same time? What at the same time? Oh, the baby stopped breathing? That's serious.
So this is a C-section? You don't want to watch?
No, I'm a C-section.
You don't want a C-section?
Right?
At this time, this time, I choose. They're really pulling this big. They're like push. They're so special. I think this is worse. Well, I mean, it looks, as far as looks, pain-wise, I can see. It just looks worse.
Okay, so now they're going to pull the head.
Are you serious? That's what they use? Maybe that's what she did. That is a huge head. I don't know how you could have pushed that up. Holy, that's an infant. That is not for kids.
Oh my God.
That is an infant. That is not a baby.
Baby's fully developed.
You see how they're stroking all the blood to push it into the baby before they cut the umbilical cord?
Wow, that's different. It does look very different. Wow. It's very twisty. It looks cool. I love how they just wear everything.
Yeah, so they're putting the baby in the radiant warmer.
Holy, these are chunky.
They're drying off.
He really is. He's so chubby.
All right, so I don't hear any breathing right now. Oh, there we go.
Is he breathing out now?
No, I get really nervous when I watch this. Maybe because of the title.
When he's peeing.
And he's crying. If he's crying,
Oh,
there's
there
some
we go.
hair movement. Yeah. He was peeing?
He was.
Oh, okay.
I run into
Now he looks like a baby. Before he looked just different. He has so much hair.
Are they supposed to like continue crying?
Yeah, then they stop it, so I don't know what happened there.
Oh, they put him, is that an oxy hood? Is that,
It was apnea, like the baby stopped breathing.
no, I'm saying, is that the container he was in an oxy hood?
Oxy hood?
Yeah, oxy hood.
Oh, I didn't notice.
Oh my goodness. How is that
9.4? That is huge.
It's probably all from nothing. It is like three.
All right, so the baby was placed in a radiant warmer. The way that a radiant warmer works is if you put your hand in the middle, you feel no heat, but the skin will absorb the heat. So even though this is completely open, you think, how is heat from up here going to get down to the newborn down here and keep them warm? But the heat will be absorbed by the skin and it'll stay warm. There's also a sensor that can go on the skin that monitors skin temperature, and it's hooked up to the radiant warmer. So if skin temperature drops, then the radiant warmer it'll project more heat. We talked about this. The onset of inspiration occurs with the cold skin. That becomes a stimulus. The touching of the newborn, and then the PO2 drops in the arterial blood, and that stimulates the chemoreceptors in the brain to start breathing. Also, the acidosis from the CO2s climbing before they take their first breath will stimulate the chemoreceptors and send the signal to the diaphragm, hey, take a deep breath. And then the strong initial first breath generates minus 40 to minus 70 centimeters of water to overcome the fluid-filled airways and to open the alveoli. So that first breath takes a lot of energy and a lot of effort, and then after a couple breaths, it becomes a normal amount of work. All right, so we'll go through the first few minutes of delivery, and then you guys can have lunch. All right, so we'll go through what happens in the first minute through the 5th minute. We're going to have an admission or a delivery for you in advanced equipment at the end of the semester. And then in the spring in the simulation center, you'll be presented with a newborn and asked to take them through the first few minutes of life. So we'll start with the notes for today. So minute 0 to minute 1, the first thing you do is you want to get the infant warm, because it's 98.6 in their environment, and then once they come out into the room, it's 72 degrees. So you need warm towels. Usually they're kept in towel warmers and then wrap the infant in the warm towels. And they're placed in the radiant warmer, so again, that'll keep them warm. You stimulate the newborn just by drying them, by suctioning the nose and mouth with a bulb syringe. It says only suction babies who have obvious obstruction to spontaneous breathing or who require positive pressure ventilation. So there was a new textbook that came out, and that's what it said: avoid using the bulb syringe and suctioning. Well, I had sent a text to Rolf wanting to know, hey, is this what you guys don't suction with a bulb syringe anymore? By the time I already printed this is when he responded, yes, absolutely, we suction the nose and the mouth. So I put down what was in the textbook I was looking at, that you don't suction unless there's obvious obstruction. And Rolf is saying, no, you still use the bulb syringe, you suction the mouth, you suction the nose, just like we saw in the video. With the EKG leads, it's the most accurate way of measuring heart rate. Another way would be to feel the umbilical cord stump, because it continues to pulsate after birth. So you could get a heart rate by feeling the stump. You could get a heart rate by using your stethoscope and placing it over the left side of the chest and listening to heart sounds. But as far as accuracy, putting the EKG leads on and hooking up to the monitor gives you the most accurate heart rate. Next thing you do is put the pulse oximeter on. It goes on the right hand, and there's a reason for that. We talked about the ductus arteriosus and where shunted blood will cross over into the aorta, but the right hand will always get freshly oxygenated blood. Even if there's shunting going on with the ductus arteriosus, The right hand will always give you the actual freshly oxygenated blood. So, should you put the pulse ox on the left hand? No, because that's going to be a questionable O2 sat. It might have shunted blood. It's better to put it on the right hand. You're going to get the freshly oxygenated O2 saturation. Then you assess the appearance. You look for breathing. You assess the heart rate, and you assess your oxygen saturation. And it'll tell you what to expect and what's normal. So if the heart rate is less than 100 per minute, it's usually because the baby's not breathing enough, so you're going to start positive pressure ventilation. And next week we'll start airway, neonatal airway in the lab, so you'll be going through how to ventilate them. So you begin with room air, and then you start titrating the amount of oxygen by using a blender. So instead of just having oxygen flow meter into the wall, you have a blender in the wall, and then you titrate your oxygen. Start off with room air, bag, and you're going to look for your O2 sats to start coming up. So it's normal for O2 sat to be about 60 to 65% during the first minute, and then it should start coming up. So by minute 2, if it's not rising, then increase your oxygen percentage until you get to the expected O2 sat. And this is posted. I'm sure all of the neonatal therapists have this memorized, but this is posted, so you can look to see if you're in range or not. You ventilate with a peak pressure of 20 and a PEEP of 5, and you ventilate with a rate of 40 to 60 breaths per minute. All right, so that brings us to minute 2. If the heart rate is greater than 60 per minute, but the infant is flaccid. Flaccid means the extremities, instead of being flexed, they're flaccid, not flexed.
So just like
Outstretched, I guess?
limp.
Limp.
Yeah, very limp.
Yes.
That's a good word.
So if the infant is limp, if they're cyanotic, so blue skin, and they're not breathing, continue ventilating with positive pressure ventilation to get your sats up to about 70%. If the heart rate is less than 60 per minute, you need to do compressions and then also get the infant intubated. So when you're compressing, you're going to use a thumb technique. Do you know what that means? Okay, so you learned that in your CPR class, how to use your thumbs to compress? It says that the duration of the downward stroke should be somewhat shorter than the duration of the release. So like a quick down, and when you release, it's a little bit longer time. So down, release, release, down, release, release, down, release, release. So you have a little bit of time for blood to come into the heart, and then you're squeezing it back out again. And then you have to do that 120 times per minute.
That's interesting.
That's twice in a second. So it takes practice to coordinate that. You know, pressing down, releasing a little bit longer, but doing that 120 times a minute.
Your thumbs would go out.
Yeah. Be aware of a tight grip around the thorax, as that will impede ventilation. So, you know, in the heat of the moment, if you're squeezing the chest too much, now the lungs can't expand normally. So you have to be aware that you don't want to squeeze the chest when you're doing your compressions. After 60 seconds of compressions, you stop and assess the pulse at the umbilicus. In minute 3, you would intubate. So this is assuming that they're not breathing on their own. I mean, if you do some positive pressure ventilation, heart rate's less than 60, and you do 60 seconds of compressions, and now they're awake, crying, and moving around, then you don't necessarily have to intubate. So just with respiratory suppressions, then they're intubated. Epinephrine is given. That's going to stimulate the heart. It's going to increase the blood pressure. You're going to be quizzed on epinephrine being a 1 to 10,000 dilution when you deliver it. And the dosage, you have to know, 0.1 milliliter per kilogram of body weight. The umbilical artery or the umbilical vein is very easy to start an IV line in that, rather than having to look for an IV in the head, which is a very vascular place and easy to start IVs in newborns. So right at birth, it's easy to just stick a catheter into the umbilical artery or umbilical vein. And drugs can be given. If the catheter is not placed and epinephrine is given via the endotube, the dosage is different. It's 1 ml per kilogram. So the reason for giving the epinephrine is to increase the blood pressure. You need to achieve a mean blood pressure equal to the gestational age. So let me give you an example and see if you can figure out if the mean blood pressure is good enough. So there's a 30-week gestational age newborn, and the blood pressure is 40/20. Is that a good enough blood pressure? All right, so we want the mean blood pressure to be 30. So let's figure out if it is. Do you remember it's systolic plus 2 times diastolic over 3? Right.
Could be 80.
So 40 plus 2 times 20 is 40, so that's 80. And then divide by 3,
That's 20.
28. Who has a calculator?
26.6.
So it's a little over, so it's good.
So is that blood pressure high enough for this gestational age? It should be a little bit higher, right? Yeah, we wanted to have a number of 30 and we've got 26.6. All right, so in minute 4, if the FiO2 requirement is greater than 40% in order to keep your O2 sats where they're supposed to be, then you give surfactant. So the dosage for Curasurf, did I put it down here in my notes? Guess not.
Was 2.5?
Yes.
2.5?
Yeah, how did you know?
Pharmacology.
Okay. So can you write that in? Yeah, I put all my notes below, but I don't know how to make them show up. It says notes.
Okay.
So 2.5 mLs per kilogram. So if the baby weighs 2 kilograms, how much Curasurf would you give? 2.5 times 2?
5.
Yeah.
5 mLs. All right, if the infant is preterm with RDS, then you place them on nasal CPAP. Oh, so we stopped at minute 4. All right, so do you want to take a break and then we'll do some more lecture? You want to keep going for a couple minutes? You ready to take a break? You ready for your lunch? Okay. All right, so 30 minutes and then we'll keep going.